Good afternoon. This is the 2021-2025 Cancer Plan webinar series. And today we're going to be talking about health equity in the 2021-2025 Cancer Plan. We're very excited for this webinar today. We actually have a nationally known presenter that we'll hear from, as well as our own coalition chair and a member of our health equity work group. My name is Shantae Davis Patterson, and I'm the program director for California's Comprehensive Cancer Control Program. And we administer the coalition, the California Dialogue on Cancer, or CDOC. Just a few housekeeping. Everyone has been muted upon entry, but you can take yourself off of mute when we get to the Q&A period. We do ask that you hold your questions until the end, but you can also drop them in the chat. We are recording this, as I mentioned at the beginning, and we also have an evaluation link we'd like everyone to fill out. So please do help us in evaluating this program. For this webinar, we're going to present a broad overview of cancer plan objectives that aim to reduce cancer-related health disparities that are included in the newest iteration of California's cancer plan. We'll cover the cancer and sexual and gender minority section in the cancer plan. And then we'll hear from Dr. Scout on sexual orientation and gender identity data collection efforts, best practices of those efforts, and then also a little overview of what our work group, the CDOC Health Equity Work Group, is doing. So just briefly, our 2021-2025 State Cancer Plan was just recently approved by the California Department of Public Health. It is still currently being laid out by a graphic designer, but we now have all of the chapters listed on our cdoconline.net website. And you'll see the website that's dropped in the chat, and you can go straight to our State Cancer Plan, and you can view the chapters that Laura will be reviewing today. Today, the topics that we'll be going over, or the chapters that we'll be going over in the cancer plan, are the Equitable Access to Care chapter, as well as the Cancer-Related Health Disparities chapter. Now, we don't have a health equity per se chapter in the cancer plan, but we are pulling out these sections that relate to achieving health equity. And we also want to note that there isn't, in each one of the chapters in each section that's included in the new iteration of the cancer plan, there is an objective that's related to reducing a disparity for all of these topics that you see on the screen. So when you visit the different chapters on the plan, you will be able to see what those are. So I'm delighted to introduce our speakers today. You can take a look at their bios. We have a lot of stuff to cover today, so we're not going to go through the entire bios, but Zool will be dropping those in the chat box that you can download and review their bios. But we'll hear from Laura Nathan. She is with the American Cancer Society, as well as the American Cancer Society Cancer Action Network, and also teaches at Mills College and retired from UC Berkeley. We'll hear from Dr. Scout from the National LGBT Cancer Network, and then also our coalition chair, Zul Sarani, who, as many of you know, is with Cedars-Sinai. He is the Associate Director of the Community Outreach and Engagement and Partnerships there. So without further ado, I'm going to turn it over to our first speaker, Laura Nathan.
Okay, thanks, Shantae. As Shantae just said, the California Comprehensive Cancer Control Plan for 2021 to 25 has been approved, which is very exciting news. And I really do encourage you all to use the link and read through the plan. It's an excellent document that was developed by CDOC in collaboration with stakeholders. And as CDOC is not responsible for the plan's implementation, the intention of this plan is that stakeholders will use it as a guide for all of their cancer control work. And in general, you know, the primary goal of this plan is to reduce the burden of cancer in California. And so it covers a wide range of topics and identifies objectives and strategies addressing issues throughout the cancer continuum. And so today, as Shantae said, I will be discussing the plan's overarching attention to cancer-related health disparities. I will also focus a little on the American Indian Alaska Native population and the tribal cancer plan. And then I will present information on equitable access, which is, I believe, chapter 6 of the plan. And you can see here on this slide that Shantae put up, this is the team that worked on cancer-related health disparities. It's a group with a lot of different backgrounds and affiliations, and an overriding feeling and intention of the group that while it is crucial to reduce the overall cancer burden in California, it is also essential to reduce persistent disparities in incidence and mortality. And so the entire plan is really intended to accelerate the elimination of cancer-related health disparities while we reduce the overall cancer burden. As Shantae said, the cancer-related health disparities team was a little different because they didn't have their own objectives and strategies, but rather they guided and reviewed the work of all the other teams as each team developed at least one strategy focused on disparities. Okay, next slide, please. Okay, so the National Cancer Institute definition of cancer-related health disparities speaks to harmful differences in health risk measures and outcomes when comparing groups. Major dimensions of health disparities include unequal access to timely, sufficient health resources, and this includes supportive care, inadequate quality of care, and poor disease outcomes. Okay, so in this slide that you see here, these are some of the persisting disparities. And, we know that depending upon what group you're in, you may have a higher risk of, late stage diagnosis, early death when compared with the majority group. And so, you see race and ethnicity, economic status, sexual and gender minorities, women, geographic locality, all contribute to disparities. And the American Indian Alaska Native population has very significant disparities when comparing them to people who are not in that group. Okay, so it's important that we take a very broad view of all of this because there are many things that contribute to disparities. And the health equity team, or I should say the cancer-related health disparities team, because the health equity is the work group now, talked about, disparities existing on the individual level, the system level, the cultural level, and that various factors contribute to these disparities. There are clearly cultural barriers to getting care. With regard to research, which is why data are so important, often there's inapplicable health models so that the model is set up for one group and it doesn't really apply very well to the other groups. Another factor that's very important is policies that actually impede care, and there's environmental issues and much more. And when you think about all these things, each of them can compound others and other existing challenges. So it's very important to try to get a view of, the many different variables that contribute to all of this. And while doing that, it's important to remember that when we think about the impact on any one individual, no one is just a member of one of these groups. We all are many things, and there are multivariate effects that contribute to cancer-related health disparities. The plan promotes an intersectional lens. And it's important to use this lens as issues of sociocultural power and privilege come into play and need to be tackled along the entire cancer continuum. Okay, next slide, please. Thanks, Shantae. Okay, so when we think about the social determinants of health and their interrelations and how they impact people, we know that they will have an impact in how people are born, grow, live, work, and age. And again, it's this multifactorial concept. We know that California is incredibly diverse. We're diverse racially, ethnically, socially, economically, culturally, and geographically. And all these considerations need to be taken into account as we address the cancer burden. We also know that environmental, institutional, and cultural barriers exist all along the cancer continuum. So the cancer plan emphasizes the need to work for inclusion. And when we talk about inclusion, we talk about many areas where inclusion is important, and the plan highlights the importance for inclusion in research, in collection and use of data, and also in the promotion of health policies and practices. All right, we can go to the next slide. And I want to talk very briefly about the American Indian Alaska Native population. The American Indian Alaska Native population in California is a highly diverse group. And we can think about this, they're diverse geographically, historically, culturally. And in addition to being very diverse and living in a variety of places throughout the state, there are also some particular concerns with the American Indian Alaska Native population that result in additional challenges across the cancer continuum. This group has a history of physical relocation, often not of their own choosing, a lack of trust, a historical lack of trust in medical professionals, and often members of this group have faced trauma, both in the past and more recently. And we know that this group bears more significant disparities than those in the general population. And probably part of that, and sort of making that even worse, is that people in this population are more likely to be low income. And so there's really an issue with resources. If you look at the problems that are apparent and more pronounced in the American Indian Alaska Native population, you can see higher rates of tobacco use, obesity, diabetes, physical inactivity, heart disease, suicide, and a number of chronic diseases. And along with these issues, they typically have more limited access to health care for a variety of reasons, but especially because many of them are living in rural areas and need to travel long distances to obtain services. Added to that, the subject of cancer is taboo among many of these communities, and all of these factors can lead to a much higher risk of late-stage diagnosis and lower rates of survival. The American Indian Alaska Native community has its own tribal plan. So we've included the tribal plan in the California Comprehensive Cancer Control Plan, but it's really their own plan, which is guided by the California Tribal Comprehensive Cancer Control Program. And the process by which it's developed is it's really a parallel to how the California plan is developed. And CDOC participates in the process of developing that plan, but it has a slightly different timeline and a slightly different emphasis. Their objectives and activities highlight evidence-based interventions, and the plan also focuses on the prevention and survival needs of the American Indian Alaska Native communities in California. Like the overall California Cancer Plan, the goals of the tribal plan are aligned with the CDC's National Comprehensive Cancer Control Plan, and an important goal is increasing cancer control health equity. Specific objectives in the plan target those areas that I mentioned: smoking, obesity, screening referrals. There's also an objective to increase public knowledge of the burden faced by American Indian, Alaskan Native survivors, and also the access of quality of care for all, especially the underserved in the community. Okay, next slide, please.
Laura, I'm sorry, I have to interject that you're out of time right now. So I'm gonna go to the next slide, and if you can just briefly go over.
Absolutely.
Yes.
Absolutely. Okay, so the objectives that we have in the Equitable Access chapter have to do with the issue of being uninsured or underinsured, financial and geographic barriers to equitable quality care, and cultural and systemic obstacles to cancer care. And we have a number of strategies for each one that emphasize collaborations, data collection, assessments, outreach and education, and supporting advocacy and policy development. And I'll turn it over to Zool.
Thank you so much, Laura and Shantae. So for the first time ever, we have a section in the plan that focuses on cancer and sexual and gender minorities. So this is really exciting. And there were several strategies that were recommended based on the background literature and the data that the team that pulled this together recommended. So, one of the objectives that has emerged, a strategy that has emerged as an important strategy for the health equity group, is to develop a systematic and consistent method of collecting SOGI data, sexual orientation and gender identity information in healthcare settings and in cancer registries. That's where it starts. And this strategy is aligning with a strategy within the cancer surveillance chapter. So a lot of energy is being put behind this strategy. So we're really excited about it. Another strategy is to create more awareness around providers and develop CME courses that meet the Institute of Medicine's core competencies. And an important topic that Dr. Nathan brought up was this topic of intersectionality, where people belong to multiple minority groups and their risk for cancer is different. And so, that's really important to share with providers as well. And then, one thing that we also realized in the literature was that there's a lack of access for this population due to lower insurance rates. So creating programs that provide free and low-cost prevention, screening, and diagnostic treatment services that are culturally tailored are really important for this population as well. Compounding to that is the fact that this population faces discrimination as well. So it's really important to reach out to this community. And then lastly was to encourage more research in this population. And we really don't have evidence-based interventions that work for cancer screening, prevention, And so we were going to work towards influencing the University of California to develop special initiatives to increase research around this population. So I'm now going to hand it over to Scout. Thank you.
Thanks a lot, Zoel. I appreciate it. All right, we're going to go a little romp through data collection, looking at some of the trends and some of the strategies. There's a fair amount of slides here, but there's less you have to take away. So I leave the slides in so you can continue to reference them in the future. We can go to the next slide, please. Oh, I do love it. The black bars are just randomly throughout everything. All right, fine. And there's some odd hanging G's now too on my screen at least. Okay, so the National LGBT Cancer Network, in case you're not familiar with us, we really focus on educating our own communities about our cancer disparities, advocating to make sure that we're included in mainstream cancer work, and doing lots and lots of trainings. Next slide, please. We are one of CDC's 8 tobacco and cancer disparity networks. So if you are not familiar with all 8 of us, we all do very similar things. Like we identify knowledge gaps, we try and convene experts in the field, we offer trainings, do technical assistance, different things like that. So again, if you're looking for resources for any of the 8 underserved populations, I encourage you to reach out to the networks. Next slide. We have a whole bunch of newsletters that go out and a lot of resources available. Actually, if you can go to the next slide right after this, we have an online resource library as well that collects as much as we can find. So if you're doing information, anything that's reaching out to the LGBTQI population, we would love it if you can give it to us so it can be somewhere and stay there and other people can look at it and use it to jump their work that much farther forward. And also we encourage you to come and look. One of the things you'll see that we have a fair amount of is media materials that you can also customize and put your own brand on as long as you're an organizational member for free. So if you are not yet someone who is getting our newsletters, I actually invite you now. If you feel like being signed up, we'll make it easy for you. Just put your email in the chat box. We'll get all those and make sure that they're added and signed up so you can be added to the newsletter. So feel free to do that right now. We've got Clark, one of the other employees on, who will get your email and make sure that you get our stuff. Next slide. So data. So we started to get a hint a little while ago. Through most of my adult professional career, the number of queers in the world, in the US population at least, has been staying pretty steady at about 4.5%, something like that. But this is 2017 behavioral risk factor surveillance system data where suddenly we started to get a hint. As you know, behavioral risk factor surveillance system is the adult version. It has a youth version. This is the number of queers that were self-identifying on the adult version of the survey. Now, if we go to the next slide, you'll see the number of queers that we're identifying on the youth version of the same survey. And yes, I'm deliberately using the bisexual flags here because of course the largest group within the queer population is the bisexual community. As you can see, it's almost doubled here or more than doubled. So suddenly we started to get a sense, the number of people in our community was starting to change, presumably as people got more comfortable closing and felt a little bit more safe. Next slide, please. And then Gallup came out in 2020 with some really interesting information as they did once every great number of years, they do a full population study and found out that the number of the full population really was shifting to the point where actually right now is 21.4 million across the US population, which means that it's equivalent to the population of the full state of Florida is how many queers there are in the United States. As people may be familiar, while we have protections in some states and localities, we do not have evenly civil rights protections across the full country. So that means lots of us approach all of our interactions concerned that we may not have a safe net in case someone treats us as has been the history in so many instances. Next slide. And as you can see, the Gallup poll really started to show how this is changing by generation. You see this is the percent of people by generation who are disclosing as queer of some variety. And if you go from traditionalists, baby boomers, Gen X, millennials, and then down to Gen Z, you see, next slide, that it is starting to look like there is a great increase of queers in the population. We get down to the point where with Gen Z right now of the adults, over 15% of Gen Z, I think it's 15.9%, are disclosing as being queer. So in other words, we have a population that is rapidly growing. Where it's going to stop, we don't exactly know. I did a calculation based upon some older numbers and found out that the year 25, 32 or something like that, the population was going to be majority queer. Who knows if that's going to happen? We clearly need to take our vitamins in order to even find out. But the point is, many more people are feeling comfortable identifying, and that means that the onus on us to make sure that we're treating this population successfully and that we're doing good outreach and data collection definitely grows. Next slide. Yes, and thanks to the people putting their emails in. Feel free to keep doing it in case you want to receive newsletter mailing materials. A point about this population, our population, that I want to make sure is not lost is that actually more of us identify as BIPOC, Black, Indigenous, people of color, than the general US population by a fair difference. 42% of queers are identifying as BIPOC. So when we talk about intersectionality, it's like almost twice as important, this population, because many more of us actually start from a very intersectional beginning. Next step, next slide. And of course, you gotta have a reason to have Lil Nas in all your presentations. Otherwise, what are you doing with your life? Okay, in the same way that there's a growth in the population, we're also seeing a matching growth in the amount of data collection. Here you see the number of states that adopted sexual orientation, gender identity, data collections measures on that same births surveillance system stuff. And it went from like 1 in 2008 up to 39 in 2020. So it's a huge increase in the number of states saying that this is important for us to add. Next slide. And this is one of the only systems that the states can make their own individual decision on as part of a national system. One of the things that pushed this is really COVID. So we had, let's just say, data collection with this population has become an even hotter issue as a result of COVID. We know that COVID really shone a light on health disparities and what it meant, particularly for Black, Indigenous, Latinx populations. And suddenly health disparities were not an abstract concept, but something where we could see lives being lost and we could measure lives being lost. Next slide, please. We couldn't do this for queers because there was not data collection, despite, as you can see here, increased risks for our population. And as a result of those increased risks, we pretty much would have to be winning the lottery not to get the increased negative outcomes from COVID. So
Scott, we have a question about
Yeah,
what is BRFSS?
Oh, I'm sorry, Behavioral Risk Factor Surveillance System. It's a federal survey done in conjunction with the states, where the states get to choose, in this case, whether they want to add LGBTQ data collection or not. Thanks, Clark, appreciate that. So increased risk for COVID, likely increased negative outcomes, and yet you weren't seeing any headlines about our disproportionate impact. Why? Because data are not being collected. And this is really relevant to cancer too. Next slide, please. So as a result of COVID, we saw increased initiative across several states to do more of this data collection. For example, Pennsylvania had a letter signed by a whole bunch of queer organizations. As a result, their Secretary of Health decided to add it to the state's COVID testing. Next slide. Likewise, in California, I'll wait for the slide to come up. In California, a different approach was taken, but the same endpoint was gotten to, and that Senator Wiener introduced emergency legislation around collecting LGBTQ data related to COVID, because again of this concern that we don't want to have something as extraordinary as a pandemic and forever have the lessons about how it impacted a health disparity population be hidden from us simply because we weren't doing a good enough job of surveillance. Next slide. Rhode Island was the third state to collect it. We didn't do a letter, we didn't do legislation, we just did magic in Rhode Island because things can be really easy and we added the questions. It was great. Next slide. We asked and they said, sure. And so these are the questions they added in Rhode Island, just as one set of examples of how the measures were being asked. And interestingly, we've got actually a data set of 300,000 respondents to this. So I'm really interested to look at those data to see how it helps us figure out if these measures were good or where they were less than good. Next slide. So COVID moved it forward as well. There was a little change at a national level too. And so the next thing I really want to say is a trend related to this data collection is that right now it is the #1 hot button topic with all of the queer health advocacy groups. So next slide, please. We spend so much of our time at this point saying to this and that different place, data collection, data collection, data collection. This is just an example of a letter that we sent to Assistant Secretary of Health Levine, the openly trans Assistant Secretary of Health, saying data collection is our top issue. This really needs to be fixed. And then if you can hit the slider to get the animation up, hit the space bar, I guess. Yeah, thanks. This is the same thing we then sent to the Domestic Policy Council. And then you see in each one of them, data collection, data collection, data collection. So really what I'm trying to say here is there are, at this point, a lot of groups around the country, and you rise up what the issues are affecting our population. Data collection is number one. And the reason why there's a big cancer and COVID overlap is because in each of those cases, data collection is only working if it comes from the electronic health records, which is honestly a little bit of a challenging place to get. Cancer data are abstracted into the registries from health records. So when you go into a doctor's office, if that isn't asking you right then, are you queer? You'll never be able to get cancer rates for the population. And for us, it's not being asked. So despite increased cancer risks, we do not have cancer rates for our population, which drives the, okay, next slide. So like one of the things we did in our, I don't know, a decades-long effort to get data collection, but also now so many other organizations, big initiatives to get collection, is just last week, before last, something like that. We came out with a letter that was co-signed by organizations, an open letter to health leaders, and the letter said, we see all the extra pride flags for Pride Month. That's great. But if you're really interested in doing something for our population, don't just fly a pride flag, collect our data. And next slide, please. We were really actually happy that you may, some people at some of the organizations on here, I know like Equality California and things like that, co-signed this letter because there were 180 queer organizations that co-signed the letter. So that means pretty much most every queer organization that you've heard of, including a bunch of little local ones and pretty much all the national ones, all said, hey, please do this. We need you to stop just flying a flag, do something substantive. And the thing we're asking for is data collection, which is why I'm really excited that, of course, it's in the California Cancer Action Plan. And one of the other things that's kind of interesting about it too is we've abstracted what's in the cancer action plans across the country to pull out all the queer areas. So now I realize with you all making such bold moves, we're gonna have to update our summary, huh? Okay, next slide, please. And literally the same day that we came out with this letter, co-signed by 180 organizations, Senators Grvalha and Baldwin, or Representative Grvalha and Senator Baldwin, I mean to say, introduced the LGBTQ Data Inclusion Act. So they now basically have legislation in front of Congress saying we need to be counted. So what I'm trying to convey here, and there's a lot of pushing from a lot of different areas, basically saying this piece of our public health system of not collecting our data needs to be fixed. Next one. You're right, be visible, the hashtag, absolutely, Shannon. So now, how you do this data collection? I love to throw this question out because whenever you give it to surveillance people, they just kind of, they get agitas because they're like, really, is that the way to do it? No, this is not the way to do it. Don't worry, this is one of the things you shouldn't necessarily do. But I will also say, big picture, for a recent 4-year period, there was not a lot of development of better measures. There was not any investment in better measures because there was not much hope that there was going to be data collection. And so in that same 4-year period, we had this mushrooming, particularly of newer identity labels like non-binary, gender non-conforming, asexual. So at the same time, we have this growth of the population and increased identification with newer-ish identity labels. There wasn't measurement testing. So the truth is, everything I'm going to show you now about how to do data collection is usually rooted in testing that happened over 4.5 years ago, before there was more of these new identity labels. So we now are in just a scientific gap where we need to accelerate cognitive testing and field testing that addresses some of the newer identity labels. Until then, we have to deal with the fact that our measures are, I like to call them like the middle-aged people measures, which is obviously not ideal for full population, but it's what I have to show you. So that's the gap we're at. And now you know why we're at that gap, because there was that 4-year drought that we're trying to catch up from. All right, next slide. So most recently, what we sent to the White House is recommended. It's been recommended to a bunch of different agencies as well for recommended measures. And I'm saying this as the LGBTQ health roundtable of a bunch of different allied organizations, are these specific measures you're going to see right here. These have been, said yes to by the Williams Institute. You're probably familiar with them. By Fenway Institute. People may know that Fenway Institute also has a report out about how to collect SOGI data specifically in health environments. I'm not going to quote that report. It is there, and I still would support the measures. But I also think those measures, as I just went over them recently with some people who wanted to include them, they look a little long in the tooth right now. So I might lean a little bit more suggested as general population measures, but there's no particular reason why they can't be used in electronic health records and those such applications as well. So this is kind of the easiest one and the least contentious one. Do you think yourself as which one of these things? Actually in some of the measures, you even take off the words heterosexual or homosexual, because in some testing, we figured out that heterosexuals don't always realize they're heterosexual. It's a 4-syllable word, and that's kind of long for a lot of people. So I remember the first time in cognitive testing, I had a woman say, well, I'm definitely not heterosexual. And I thought to myself, I think you are. But maybe that teaches me about how people understand the word, right? So anyhow, next slide, please. And again, these are all sitting here, so you can go back and reference them. You don't need to take notes or anything like that. Gender identity, what's your current gender identity? Male, female, trans woman, trans female, trans man, trans male. I was literally on a call yesterday looking over those data, those full population data from Rhode Island, where we found out not many people chose trans woman or trans man. If male and female are also there, they usually choose that, even if they're trans. And you derive the fact that they're trans because, next slide, please. Or there you go. Oh, it's spaced funny. But because you also want to make sure you ask sex assigned at birth, SOB. So if this doesn't match the sex assigned at birth, you then realize that the person is trans, of course, right? And, this is one of the weaknesses about it. We don't usually find that, thank you, Shannon. We don't usually find that another category is good for actually capturing identity labels. So this is probably a weakness of this measure. It should be enhanced. Other is not usually the best place to put it, but nonetheless, what we have now, 4-year drought in measurement testing. All right, next slide. So one thing that's actually important about a lot of this, if anybody works with NIH, you might realize that NIH has long been grouping now LGBTQI intersex as well. And so intersex or differences of sexual development, DSD sometimes, is what long ago we would have called hermaphrodite. Now we understand a lot more about it and we're very much more educated about it. So all these national groups are always encouraging intersex data collection to happen at the same time. And we are a step farther behind with doing any intersex data collection. To my knowledge, there has actually not been measurement testing on this measure, but this is currently what Interact, the biggest intersex group, is recommending. So first of all, we should absolutely get testing on it. But second of all, we don't have places where we can see this be administered on a large scale yet. So we're going to learn some more lessons on that. But it doesn't mean we don't want to do it. We absolutely do want to do it. So this is the recommended measure for intersex status or DSD. And as I'm saying, with all these, we're encouraging this to happen along with what we call sexual identity, so SOGI, and then sexual characteristics. So we now have a new acronym because we are the alphabet mafia. And if it's not up to us to come up with new crazy acronyms everybody kept up with, then who's it going to fall to? So it's now SOGISC when we talk about data collection: sexual orientation, gender identity, sexual characteristics. Next one. Okay, so let's switch to what a cancer center uses. So that's what was recommended, is given to the White House, a bunch of other people standing on now. Now we're going to go to some older measures, but the measures that are being used by the Cancer Center that I think probably has done the longest standing data collection in our population. So this is Moffitt in Florida. They do a lot of great work, and this is what they've got. This is kind of straightforward. Next slide, please. I still would get homosexual and heterosexual out of both of those, honestly. What is your current gender identity? Again, line 3 and 4 will probably disappear if we do more measurement testing, but here we are. At least it says gender queer, that's great. It doesn't say non-binary, and non-binary is one of those biggest new growing categories, so that's not a great thing. It does allow a write-in, okay, but when we have growing categories, we should never relegate them to a write-in. And next one. So here's just some other things as far as actual implementation that are really handy to know. What pronouns do you prefer? Of course, is a really valuable thing to ask people. And I hope as cancer providers, you're also putting out your pronouns as a little bit of a flag that you're more welcoming. So they should be in your email. They should be on your Zoom profile. Oh, they're not on mine. I can't believe it. Somehow they got stripped on this one. I'm going to change that right now. Done. Okay, fixed. Better. Second of all, they also offer definitions in case you're not familiar with it, including definition of queer and questioning, which is a word that, obviously has been used as a real pejorative, but nowadays is really mainstreamed by our population. It's in a lot of our organization names, things like that. So we have to be much more conversant with it in the public health arena. Next slide. And then this is a really valuable thing. Whenever you're asking anybody to ask these questions, they're going to get some pushback because there's not as much education in the community about why they're being asked. And that means they'll get pushback from people outside the queer community, and they'll get pushback from queers being like, why are you asking me? So you have to give your people something that will help assuage those concerns. We saw long ago in cognitive testing that if you frame these questions as, we've got some sensitive questions next, be careful, then that will arouse people's concerns and fears, and they will get more jittery about it, right? On the other hand, if you instead do something like this, where you're just like, not an issue, we're asking these questions to improve the quality of your care, that wouldn't be my favorite choice. Usually what I would recommend places say is something simple as, we're asking these questions to ensure that we're eliminating all health disparities, or that we're addressing health disparities in the population, something like that. But just really matter of fact, put something in there so that people are reassured and calm down in case they have any questions related to this. Because when you do add these questions, it's not uncommon for people to complain way up the chain. So another thing you should do as an organization is educate the people up the chain as to why. So in case they get a single complaint, they aren't rocked and surprised, kind of thing. Okay, next slide, please. So what should you use if you're in a healthcare organization right now? The first thing to ask is, there are some measures already built into your software. Epic and all the big EHR software have measures. So you can just flip the switch and turn on the module, use what they have there. We know that a next gen of measures will be coming out once more testing happens, but to be honest, it hasn't even started yet. So the big thing that is the theme that is being really emphasized is, don't wait for perfection to be the enemy of good. If you've got measures right now built into Epic, flip the switch, start collecting. This is going to be a process that you are going to get better at. The world is going to get better at. So the first important thing is start the process. Don't wait until next year, until something next comes out, because you're going to have steps on how it gets better and better. Moffitt's still going through the steps, even though they've been collecting these data for quite a while. And next slide, please. Boy, I love the way all the slides are just different. Challenge is, there's a lot of opposition at the hospital level to doing this. Who knows why? I have no idea why. I don't know. If all hospitals were run by lots of queer people, maybe there'd be less opposition. I don't know. We also see that there's low compliance. If this is administered by people, we see a lot of the administrators just skipping the questions. Like Rhode Island was just talking about how it's happening the other day. And you ask, like there was an example, they asked one person why. Why do you have so many missing data in these fields? For this was a COVID case finder. And he said, well, because people get upset at me if I ask. So it's, again, you should educate the people asking the questions, and you should educate them on those small steps just to diffuse the population concerns. And again, educate them on how to make it seem just like matter of fact instead of a big issue, right? And then we do also have to do community education. So for our own population, we have to talk to us about, why is it this is being asked? If you see questions on it, it usually means people like us have fought for those questions. But the general population doesn't understand how cancer registries exist, or how cancer research is dependent upon data from registries and being able to put it together a needs statement that's strong enough to get through NIH's review process. So that's why we have to educate them a little bit on why this is a critical piece in changing our health. Next slide. And we, people might have heard that we actually have just launched the findings from our big 2,700 person cancer survivor survey. And so, oh, thanks, Zool, that rocks. Look at that. I thought Clark was gonna do that, but Zool's all over it. So if you were at the launch event, which I thought was really great, we heard from so many survivors, experts, everything like that, really vibrant stuff, really interesting. I encourage you to take a gander at it and also look at the report that came out. It's the first of several reports. We're gonna do our BIPOC report next. So I encourage you just to check out what's going on there. A lot of really interesting information that we hope will be able to improve cancer care for a lot of us. And then next slide, please. Boy, we're a weird looking bunch if you look at it this way. I think in real life, we're more normally proportional, but this is the team. And I think it's supposed to say, actually, if you want to get a hold of us after this with any questions or comments, you can email us at info@cancer-network. And also, Clark, can you put up, in case you didn't want to put your email up here, Clark, can you put up also the link in case you want to sign up through the link to get our newsletters and things like that? And with that, I turn it over to questions. Thank you, Clark.
Thank you so much, Scout. I can't believe we only have a little bit of time, but we do have some time for Q&A. So I want to open it up right now if anyone has any questions for any of our presenters. And I know we have a lot of questions in the chat as well. Maybe Shannon, if I can go to you first, just so we can address those questions in the chat first.
Yes, the one question that was submitted in the chat was answered live. That was defining one of the acronyms that Scout used.
Yeah, if you're in Virginia, we call it BARFUS down in Virginia, just so you know.
That's perfect. There was one comment that came up in the chat about the non-binary and the use of that term, and kind of how the change has been made within the queer community for the acceptance of and the growth of the non-binary just label, or I hate to use the word status, but I can't think of anything else. And whether or not that has anything to do with the fact that there are some states and now possibly passports that will have the non-binary gender option on there.
And doesn't California have it for, California has at least for birth certificates, right? Maybe even other things as well. Yeah, we've seen a huge increase in that. And part of that is, you know, youth are youth, and they always do interesting and fun things. And the rest of us kind of like struggle to catch up. But one of the things we always talk about related to the proliferation of not just non-binary, gender non-conforming, asexual, demisexual, flux, and all those interesting sort of new labels that, trust me, we learn new ones every week and we train on this, is that the really great thing about it is that when people feel they're part of a herd, it really reduces their mental health problems and their stress. So there's a lot of ways that people had felt that they were really isolated and alone, and now we're getting better and better labels for this. Just as an example, when I was growing up, the label I had kind of available to me was dyke. That didn't work out very well. Transgender had not even been invented yet. And transsexual was a very small number of people on the news that were mostly women, and I didn't understand how that related to my life. So when you get a label that fits you better, in this case, transgender and trans guy, suddenly you're like, oh, I get it. And I know how to find other people like me. And there are other people like me. So the fact that non-binary is proliferating right now is really wonderful. And you don't have to be an expert in any of this stuff because Google is free. So just remember that you want to be able to echo back the language that people come to you with. And you want to support the fact that when they come to you with something that may be an unexpected pronoun, if they're using they, them, ze, zer, or if they are non-binary or things like that, that they're probably coming with a lot of anxiety about how you're going to receive it. And the more we can take that moment to not just make sure we reinforce it to them, but also kind of look at our systems, our organizations, some of our structural stuff, and figure out if we gave them any indications before they got to that point that they would be welcome to disclose, is going to be really helpful. Because identifying as non-binary, probably because they feel a little safer. So my question is, are we part of that safety? Because when we're moot about that point and not talking about it, we're part of the danger and the concern and the nervousness. So.
Thank you. Does anyone else have any questions? You can take yourself off of mute and ask a question.
I have a question of my own.
Oh,
so Scout, there's been a lot of conversations just about the content, SOGI or SOGISC.
SOGISC, that's what we decided. Pronounce it different ways.
I'll get it one day.
Right.
But there's been a lot of questions about the content of those questions and whether or not we should be moving to models of them that ask for gender as male, female, non-binary, and then have a second step question about gender identity. And I was just wondering if you had any,
I will
if
say
you had run across similar things. Or?
I've done testing enough in this area to realize that I generally will not have opinions on how to add anything until it not only has gone through cognitive testing, but field testing too. Cognitive testing is with like 50 or 60 cases, then field testing should be with many thousands. And just even as an example, a bunch of folks led by a queer at National Center for Health Statistics did the testing on what is still used as the sexual identity question. But in the first iteration of that, the cognitive testing came up with trisexual as one of the options. Which at that point, literally, if you Googled it, you could find a reference on the internet that said sex with tricycles. So obviously, even cognitive testing alone, which is gold standard, done by our gold standard testing institution, does not actually meet the bar. So as far as the kind of how, I actually try not to have opinions. It really is test it, see what works. None of us represents a large enough slice of this really, amazingly rich and diverse population to have a sense of how people are gonna, react to all the different structures.
All right. Well, right now I do want to take the last few minutes, and we have a few more slides, and I also want to apologize to all of the presenters for any distortions in the format. This was a new format for us, so apologies for that.
That's not an issue. All right, thanks everybody. Remember, if anybody needs to contact us, info@cancer-network.org.
Thank you so much, Dr. Scout and team. All right, I'll turn it over to Shannon, who is one of the leads of our health equity work group, to talk about our activities there.
Yeah, hi everyone. Thank you so much for joining us today. I am Shannon Kozlovich, she, her, hers pronouns. I'm a scientist and the tobacco control manager at Equality California. I'm also on the CDOC executive committee with Zool, and I'm also one of our group has three co-chairs, Kimlyn Ashing from the City of Hope Medical Center, Berkman Research Institute, and the Center of Community Alliance for Research and Education, and Sora Park Tanjasiri from the University of California, Irvine, Chow Family Comprehensive Cancer Center, and myself. To reference back to what Scout mentioned about queer identities and health data earlier, the CDOC Health Equity Working Group is focusing on projects or a larger project that looks at ensuring that the cancer burden for sexual and gender minorities is represented through cancer surveillance data for this particular marginalized population. And that really is what our vision of success is. California is beginning this work through the California Cancer Registry, but our efforts will also include national collaboration with entities like SEER, NIH, and CCSG. And we've already begun this work. The work group's laying the groundwork and milestones for our 2 to 3 year plan. We are currently creating awareness and framing specific issues, identifying key partners and community members to conduct the pilot work, which will result in publications and policy briefs to help us operationalize what we are hoping to achieve at the state level. Our key milestones in this work group is first to just do a review of existing sexual and gender minority status measures that allow patients from diverse sexual and gender minority groups to accurately self-report their sexual orientation and gender identity in different healthcare settings. This involves creating more awareness around these health data within our health system, registrars, and our cancer center partnerships. Second, we're hoping to conduct a few pilot projects with our cancer center partners to see if these measures are appropriate and stable over time. At least one project will focus on intersectional barriers because the LGBTQ plus population and LGBTQ plus people or sexual and gender minorities belong to many diverse communities. We are a part of almost every community that you interact with. For example, there's experiences and data collection that look differently for Black trans women or someone who is a lesbian but also has different or multiple other intersectional identities that they identify with. And finally, we will gather feedback from the community. I'm sure that means many of you, in order to develop a white paper and to display the results from our 2 pilot projects. Our health equity group may also include other focuses as we really narrow down our priorities, but it has been one of the top priorities that has come out of all of the conversations that we have had surrounding this. And with that, I will hand it back to Shantae.
Thank you, Shannon. I see that the evaluation has been dropped in the chat. So please do fill out the evaluation for us. If you want to join the health equity group, it's right there. And also, if you want to get involved with CDOC, we also focus on other cancer topics and other cancer control and prevention activities. So please visit us, cdoconline.net. We're still updating the website, so that's a work in progress. But you can find more information and fill out a membership application. And again, please do fill out the evaluation. We would like your feedback. And I want to again thank all of our presenters for presenting today. It was a wonderful presentation. We will have the slides sent out on the recording sent out on the CDOC listserv, and it will eventually be on our website. Please be patient with us. It's a team of 1 right now with a whole bunch of volunteers. So we will get that updated. But again, please be patient with us. And you can always send us an inquiry at our Gmail. And thank you all for your time today.